So my name is Peter Haddon from New Zealand, and I'd like to talk about the history of retinal detachment surgery. Not only because it's interesting, but because it's instructive. And the common theme is that many supposedly novel ideas were thought of a long time ago, rejected, only to be resurrected a few decades later. And I'm sure the same is going to be true in the future. Retinal detachment surgery has come a long way in the last 100 years. When it was almost untreatable, only 85 cases could be found that ever were fixed, to having an 85% primary success rate nowadays. The first description of retinal detachment histologically in a cow's eye was by a French doctor, Anton Maître-Jean, whose name I'm sure I mispronounce, and he's considered the father of French ophthalmology. George Baer accurately described the symptoms and external ocular signs back in 1817, even though he was unable to observe it directly. While visualization of the fundus in vivo was first described by Jean Méry, who held a cat underwater and found he could see the posterior pole, although his optical explanation was incorrect. The first direct observation of human retinal detachment, of course, had to await the invention of the ophthalmoscope. A chap called Babbage almost got there in 1847, but an ophthalmologist colleague, Wharton, didn't think it would be particularly helpful, but he forgot to add in a minus lens. Thus it was, of course, that Helmholtz is considered the inventor of what he called the Augenspiegel. It used a series of thin glass plates, to form a partial mirror to reflect light into the eye. This was then viewed monocularly. The name ophthalmoscope was coined in 1853, and gradually the design was improved upon, giving us a compact, portable device with excellent image quality, although of course monocular and with a small field. Nevertheless, seeing revolutionised diagnosis, and over the next few years, tears and vitreous liquefaction were noted to be common companions of retinal detachment. By the late 19th century, some were suggesting that changes in the vitreous cause traction on the retina, and this in turn causes retinal tears and detachments. But despite trying drainage of subretinal fluid, cutting of vitreous bands, scleral shortening, ear injections, and forms of retinopexy, surgical success was rare, the last clutch at a straw of hope. So along came Jules Gonin, a Swiss ophthalmologist who made the study of retinal detachment his life's work. Gonin was not the first to suggest that retinal tears caused by vitreous traction were the immediate cause of what we now call regmentogenous retinal detachment, although he did popularise this theory. But in the years after World War I, he was the first to show that closing the tear could fix a detachment, and thus proved the theory. As a result, he was able to reattach more than 50% of his cases. To close the break, Gonin used hot cautery ignipuncture of the break through a draining incision, as you see here. However, of course, large or multiple tears were difficult to treat with this technique. It required precise localization of the tear, and there could be significant complications, often related to the large scleral wound and the ignipuncture itself. Other ophthalmologists, of course, did improve on the ease of the tear location, ease of locating the tear, and other forms of retinopexy were developed, including cryotherapy actually in the 1930s, but it was then abandoned and thought useless. So the next major breakthrough had to wait until immediately after World War II with the development of the scleral buckle. So revolutionary in this was Charles Chapin's. He invented the modern binocular indirect ophthalmoscope, making it a portable head-mounted device with a high-quality condensing lens, and because, of course, they had electricity by then, a bright electrically powered bulb. He also pioneered scleral buckling, and in Belgium, being occupied by the Nazis, he was a member of the resistance and managed to survive the Gestapo. Oh, that's a... Indirect ophthalmoscopy actually was not a new invention again. It was something he reinvented. It had actually been invented as long ago as 1852 by Reuter, but as you can see, it was cumbersome, fiddly, monocular, and only a dim view was possible because of the poor illumination possible at the time. And it had been abandoned in favour of the portable, easy-to-align direct ophthalmoscope by 1900. It bears mentioning also at the same time the slit lamp, invented somewhat later, was beginning to be able to use to view the retina as well. So scleral buckling evolved from observations that resecting and indenting the sclera appeared to relieve vitreous traction. Resection gradually gave way to using artificial elements such as we use today. And by 1957, a permanent implantable buckle was being used by shape-ins in most cases. What about the other elements of the scleral buckling technique, the AIOS? Drainage, of course, we've already seen with Gonin and even earlier. The use of intravitreal gas actually dated back to 1911, again another thing that was forgotten, but was not widely used until reintroduced along with gas by Norton in 1973 in Miami. So it was not a part of the original scleral buckling techniques. Silicon oil was first used intraocularly in 1965. Focused light had been developed into laser light by the 1960s. The same decade also saw the modern cryoprobe being rediscovered from the 1930s, and these techniques of causing a chorioretinal adhesion replaced diathermy. And as we know, these techniques also led to 90% success rates. Of course, as you know, some patients with severe proliferative vitreoretinopathy are untreatable with these techniques. There's also a significant recovery period after such invasive surgery. A 360-degree encirclement leaves one with perhaps 2 diopters of myopia. And you can have late complications such as exposure and infection. Of course, people did try to overcome these limitations. There was a temporary buckle devised, but the invention of vitreous surgery really instituted the third revolution. So surgeons had cut the vitreous as far back as the 19th century or removed it with sponges and scissors. Sorry. But the founder of vitreous surgery was Robert Mackema. Born in Germany and the son of an ophthalmologist, he moved to Bascom Palmer Eye Institute in Miami in 1968. Here in 1974, when my father was his fellow, was the old Bascom Palmer and the new one under construction. By 1970, Mackema was using a single probe infusion suction cutter designed for him and Buechner for use in open sky surgery, and later in that same year he first used it in a closed eye. Here is Robert Mackema performing a vitrectomy. The engineer Jean-Marie Perel deserves credit for the vitreous infusion suction cutter and fibre optic illumination used in most early vitrectomies, although it was not the first cutter. And of course, many other great minds, too many to mention, also contributed. By 1974, a divided system had been invented, although the single probe remained popular for some time. And of course, this would not have been possible with the concurrent development of the modern operating microscope, where Perel also featured as the foot pedal designer. The current non-contact system was invented in 1987. Technological improvements with higher cut rates, stiffer instruments, and better fluidics allowed the development of smaller gauge instruments and sutureless surgery. And other tools that we take for granted included the development in the 1980s of heavy liquids, so that inferior breaks did not require the patient to be upside down during surgery to allow the air to go up. Diathermy, endolaser, and intraocular magnets. Finally, one must mention pneumatic retinopexy. This was introduced in 1985 by Hilton and Grizzard to treat selected detachments, of course, with minimally invasive surgery. So to recap, the 3 major developments in retinal reattachment surgery were the recognition that the hole needed to be closed in the 1920s, which they did along with draining the fluid, the ability to relieve vitreous traction with scleral buckling in the 1950s, and the abolition of vitreous traction in the 1970s and beyond. I wonder what's next. Thank you.
Thank you so much, Dr. Peter. So now we are going to start our instruction course on my longest retina day. The caption here, please. So I will invite all my co-instructor to take the group photo first, because few of our instructors, they are going for the other instruction courses. Please, Dr. Maiti, Dr. Reddy, Dr. Vishal, Dr. Guha, Dr. Aditya, Dr. Shobik, please. So I'm inviting Dr. Aditya Kelkar for his talk on subretinal silicone oil.
Thank you, Dr. Shubhendu. It's been always a pleasure to be a part of your instruction course. Since you've given me the opportunity, I'm going to make the most of it and present not just a longest day, but I'm going to present my longest days. Starting with the first one is the subretinal silicone oil. This is a lady, 50-year-old pseudophakic patient, underwent vitrectomy silicone oil. But within 3 months, she presented with reduced vision. On B scan, as you see, there is a retinal detachment, and you could see some cystic spaces. Because of the anterior PVR, I decided to do a 360 degrees Enser clutch and then do a silicone oil exchange. With membrane peeling, that was the plan. So the scleral implants have been, implantation is planned. And then going ahead with the silicone oil removal. So the retinal trypan blue dye to stain the membranes, and then followed by removal of these membranes.
Put up the light.
So I was thinking that after the membranes are gone, the retina will start to fall back in its place, but it wasn't happening. And then I had to resort to a retinectomy inferiorly. And then after the retinectomy, I planned a fluid air exchange. But to my surprise, there's some a large cyst-like silicone oil bubble coming out from that area, obviously indicating that there's a subretinal silicone oil. So I introduced PFCL, hoping that the rest of the oil will come out through the large retinectomy site. And yes, of course, it comes out as you see. So a couple of bubbles are already out. And I still had an area of retinal detachment on the temporal side, superotemporally, as you can see. And I thought it's because of the subretinal band which is there. So I reduced the amount of PFCL. And my plan was to remove the subretinal band. So I did a diathermy to that area, and with the help of the forceps, I'm removing the subretinal band. And you can see another oil bubble there. And as I remove the subretinal bands, the site of the small retinotomy has actually become almost like a retinectomy now. So thankfully the traction is removed, but obviously there is some more silicone oil under the retina. So I increase the amount of PFCL, remove these membranes, and then one more attempt to drain out the subretinal silicone oil, this time from the temporal side. then finally the oil is out and the retina starts to settle back. So it was a real time consuming surgery which I am trying to show you in the allotted 2 minutes or 4 minutes, but it took almost for me 1.5 hours to finish this entire surgery. Finally the retina settled well and patient had a good outcome. Another interesting scenario I'll show you is I had a dislocated intracapsular whole back dislocation with the CTR, and the aim was straightforward to remove this IOL back complex. PFCL is already there to protect the posterior pole, and as I bring the lens up into the anterior chamber, I get very excited about seeing this lens in the pupillary plane, and I end up pulling the CTR out of the sclerotomy along with the trocar and cannula. So I let it go. So I assume that everything is fine. I bring the lens and the bag out, and as I examine it, I realize that some part of the capsular tension ring probably seems to have found its way back again onto the posterior pole. So this simple removal of the capsular tension ring and the whole back complex took a slight detour, and something that was supposed to come out in one piece I've managed to bring it out in 2 pieces. Thank you.
Thank you, Dr. Aditya.
Thank you.
Both of the cases were perfect longest day cases. In your first case, I want to ask you one question, whether you have not anticipated it preoperatively, the silicon oil was behind that, because
by the look of the B
lot
scan,
of posterior PVR was there, lot of anterior PVR was there,
Yeah.
but retinal silicon oil didn't realize.
so as you can see from the B scan, it didn't appear like a routine subretinal
Very
fluid.
difficult to
So
pick it up.
from that, it was quite clear that it's going to be a subretinal silicon oil.
Wonderful presentations as
Thanks.
usual, very thought-provoking. But the difficult situations, one difficulty is when there is heavy oil there, and because the lighter oil floats up easily, so whenever you have an opening, it floats up. The heavy oil is the real challenge. But anyway, having said that, one small thing that one can do is, when you are making a retinotomy, which should be as peripheral as possible, initial retinotomy. And if you see subretinal bands, you continue the retinotomy in the same plane, peripherally as much as possible, so that, because posterior retinotomies are prone to extension, as you saw, and increase in size and greater PVR cycles.
Thanks.
Thank you. So I'm inviting Dr. Aniruddha Maiti for his presentation.
Okay, I will be showing few cases. Like the first one, this was not anticipated to be a long one because it was a non-resolving vitreous hemorrhage. Once we got rid of the organized vitreous hemorrhage, we could see there was a sub-ILM bleeding. So nothing big deal, it's a simple procedure of we can just peel off the ILM and take out the blood. And that's what we are doing. Once this ILM is off, it's our job is easy. We are going to flush this blood off. Fine. So that is also, we have got rid of the sub-ILM bleeding. Now we are doing the peripheral base dissection. There was a lot of hemorrhage for a long time. So we are shaving the vitreous. So we were just about to close. Something happened which was not anticipated. Yes, can I just pause it? uh, there was a bout of cough which was just not stopping, and this patient literally was sitting on the table, and there was spot of blood. Not only, obviously, we could not see what is going on inside. We just took out all the instruments, but we could see the blood outside also. Obviously, the valve cannula didn't work properly. So what we saw inside, now there was a choroidal suprachoroids, and while manipulating my cutter through that, I induced an iatrogenic RD as well. Now the bleeding was even worse. Fresh bleeding. It's sometimes, obviously, this is an edited video. It took a long time to take out this blood. In fact, manipulation of the instruments was pretty difficult. So ultimately, we got rid of the blood, but we need to take care of the suprachoroidal, the choroidal detachment, as well as the RD, which has been there in the supratemporal quadrant. After settling that, we had done a previous cryo as well in that area, and then did a good laser. And luckily, we got through this complication which happened intra-table, like it settled well. And later on, we have removed the oil, and the patient is doing good. Now, this is a trauma case. As we know, the trauma comes with a lot of surprises. This was a globe rupture, and this patient had a head injury as well. So he was admitted in the general hospital for 2 weeks. Nothing was done to the eye, and ultrasonography was also not possible. So what we planned, we'll do this globe rupture first, and then for a plan for a second stage operation dealing with what is there inside the eye. So that was our initial plan, but keeping in mind that this patient has already undergone 2 weeks in a general hospital due to the head injury, we need to see what is there inside. So while we were doing this globe rupture, we saw there was a lot of extension in the scleral rupture, so we had to disinsert the muscle. And once we disinserted, the globe rupture was repaired well. And as I was mentioning that we had to see what is there inside, because we didn't do an ultrasonography. We cleared the hyphema. And then with the cannula inside, we saw this was the scenario. There was retinal detachment, there was choroidal detachment, there was choroidal rupture. So as already 2 weeks has passed, we thought we have to do it as soon as possible. So in a single step operation, we actually operated this, and then we removed the cataract first to have a better visualization and better management of the posterior segment. And in fact, we saw the choroids over there. So I thought I will put a AC maintainer and proceed with the case. Now, as you can see, there's fresh vitreous hemorrhage, underlying retinal detachment, on the temporal side, choroidal detachment as well as choroidal tear. Now, getting rid of this vitreous hemorrhage first. And once the posterior pole, we could clean it up. To stabilize the posterior pole, we put PFCL to deal with the periphery. It's difficult to dissect the periphery, so put the PFCL to stabilize the posterior pole, and then we did the rest of the vitrectomy in the peripheral vitrectomy. The residual posterior vitreous detachment was done, and then gradually the entire retina was settled, and we did a 360-degree laser. We could not drain the choroids because the eye was, as I showed, there was a huge globe rupture, so it was soft. So we thought we will do a conservative management, and then did a direct silicon oil PFCL exchange. That's the last bubble of the PFCL. So Luckily, this eye actually we could save the eye. Not only save the eye, we could give a good vision, almost 624 vision, and later on we have removed the oil as well. Coming to the last case, this was a comparatively simple case. You can say a pseudophakic RD, and there was one large break, but the other breaks were pretty small, very typical of pseudophakic RD. But what was there was a choroidal detachment as well. Mark the peripheral breaks. And then did a fluid air exchange, and as the breaks were mostly anterior, we had to do a retinotomy and did a good laser as well. So on table it was absolutely fine, but some surprises happened within 7 days of this post-op period. This patient came with a redetachment. I was very surprised why this redetachment has happened. So I thought I have missed a break, or there's new break formation. So I took the case again after 7 days. What we did not do in the primary, we didn't drain the choroids. We thought it will come down conservatively. So we didn't see any missed break as such, but the choroids had subsided and there was a reopening of the existing breaks. It is pretty much similar to what Aditya had showed, but it was not that, the PVR changes were not that severe because this was taken only 7 days post-operatively, and we realized that there is a huge subretinal oil bubble, and the only way we could release that, we had to do a retinectomy, relaxing retinectomy, and release the silicone oil. So once we did this relaxing retinotomy, the entire oil came out, and then we settled the retina well, and eventually this patient did pretty well. This is 660, but post-silicon oil it was 680. Yes, what went wrong in the last case, which was a completely simple case, maybe non-drainage of the choroids, underfill of the silicon oil later gave rise to PVR change and then shortening of the retina, which led to this redetachment with subretinal silicon oil. So that was about the cases. Some were simple cases, went to a long day, and the last one was a simple case. Later on, it was a difficult one. Thank you.
Thank you very much, Dr. Maiti. So I'll invite questions from the audience. Dr. Talwar, Dr. Gupta, please.
Yeah, I do, but this patient, RD with the CD, was quite hypotonous. So I thought it was not that severe. So I will, many cases, there is little bit of choroids do subside with time with oral steroids and conservative management.
What is your preference? You try to drain from a separate sclerotomy, or you take out the cannula and then drain? Like,
I will do.
If you have to drain it.
Yeah, I do it
table.
with a separate sclerotomy.
So your sclerotomy is somewhere at the maximum.
At that dependent part.
Yeah.
Dependent part.
Can you just make a small comment on this? See, I don't know if you people remember those times when we had 20 gauge instruments.
Yes.
And choroidal detachment was never an issue. It was never an issue because it used to drain spontaneously while you were doing the surgery. All you need to do in your cases with choroidal detachment, with the retinal detachment is, after you put the infusion and you put in the other two cannulas, remove the cannulas when you do the surgery.
You mean serous?
Just remove the cannulas and do the surgery. No, you don't have to do anything. Just do your normal surgery after removing the cannulas. The upper temporal and the upper nasal cannulas. You remove those and you do the surgery. By the time the surgery finishes, the choroidal is drained. There is no separate drainage needed for them. Right? So all these problems get sorted out automatically. You don't need a separate procedure. You don't need another sclerotomy. You don't need another site. You don't need to do anything, provided you do this. And of course, I would use a little bit of PFCL at the posterior pole so that whatever is there absolutely at the posterior pole moves forward. And the rest will take care of itself. I don't know why we are not realizing this. This is an iatrogenic problem. Not draining the choroid in a combined detachment
is a nitrogenic problem due to 23 or 25 gauge instruments. It is not a problem that needs any separate answer.
But the thing is
what
that
I
if you
used to
are not doing draining the fluid, it will that the opening, and when you are just removing the cannulas, the space, the peritomy, the sclerotomy site will be easily missed under the conjunctiva, because we are displacing the conjunctiva and the making
Small two peritomies.
small peritomies.
Just
That
two
is-
small
that's
peritomies, so
possible.
that so otherwise there'll be bogginess of the conjunctiva. With this, no bogginess of the conjunctiva will occur. You need one suture on each side.
what
In
I
case
do.
of serous, point perfectly taken in a combined detachment and RD situation, serous choroidal detachment and RD situation, which is the fluid is serous. Yes.
No, what I do is ki I just go inside and then I take off the cannula, and just within limbs forceps you stretch the upper lip. Automatically the fluid will come and half of your choroidal attachment will go. Enter again with the cannula and you complete your surgery with that.
Thank you.
But most of the cases actually drainage is not required. They do spontaneously resolve. But this was a
very much
one of a kind of case which actually landed up in a redetachment.
Like
Yeah.
that is
And
that is true.
post-operatively they do pretty
But
well.
when you are injecting the silicone oil, that will falsely give you like underfill.
Yeah, that
The
happens.
point I don't understand is why did silicone oil go under the retina? Because
Yeah, this
merely having a choroidal can only lead to an underfill. It cannot cause silicone oil going under the
that is the reason I have put the questions that what went wrong. Because this was also my question.
Did
Why
you
did this silicon
did you
oil?
drain fluid under silicone oil?
Yeah.
No, when you drained, when you did the SRF drainage,
no.
did you do it with silicone oil there?
No.
Because that
Silicon
can cause
was-
this.
I showed it. Like the drainage was done. Then later on the silicon was given.
Yeah,
It is
and at
not
that
under
time there was
silicon.
no silicone oil under the retina.
No. It was
Then the other
perfectly
thing-
fine.
Then I'll
Actually,
tell you
I
what
showed
has
the
happened.
post-op.
Actually, what has happened is that your choroidals were there, and your ports did not go full thickness. So when you shifted to silicone oil, part of the silicone oil dissected through the port. at
Then the
cannula.
next day I would have seen that.
No, you won't see it initially. You will see it after a few days when he's lying
It
prone.
happened after 7 days.
No, he didn't see. He says he didn't see the next day.
It
He
was not
didn't
there.
see because it won't be there the next day. It'll only happen after a few
That's
days.
quite possible. That's quite
So
possible.
and the other thing, when you have a choroidal, I don't know whether you did that, but when you have a choroidal with a detachment, your first step is to be with a 2 ml syringe, put enough fluid inside the eye that the eye
It
is
was
hard.
not it was not that hypotonous.
No,
Yes,
so
we
the
do
point I'm
that.
trying, what you think is not that hypotenuse. Also, the problem that will happen is it will go into the subretinal space.
It is a good presentation, sir. I admire Dr.
Yeah. I'm not. I said I'm just pointing out that.
I am only saying one thing. Have you followed this patient? How much?
Yeah. They're all patients are following up.
Any complications?
No. We have after this second operation they're doing fine.
Yes.
Hypotony maybe after
Could have been there.
use retinectomy. You have given
Yeah, it is true, but with relaxing retinectomy there is hypotony, but this patient is doing well.
changes can develop after putting this retinectomy through insert place near about on 360 near much.
No, this was not done that much. The patient is doing fine.
No, nobody is
Yes,
denying
everybody-
it's a beautiful
all
case.
beautiful.
I am
That's
just
why-
telling. In
that's
fact,
why Dr.
because it's a
Talwar is
beautiful case,
highlighting many things.
it's
like
very
that.
important. What you just mentioned.
Nowadays there is some experience of ourselves also.
So
Yes,
the
yes, sir.
May not think it is a superior.
No, sir.
So that it is discussion.
Yeah, so the basic point I'm trying to make is that when you make it a hard eye, even when you think that the hypotony is not too much, the choroid flattens out. So it becomes easier to, so then this problem of a dissection from the other two ports doesn't happen. So that's the reason.
30 gauge needle and you enter and make your globe hard.
Thanks, Dr. Talwar, for
Thank
wonderful
you so
points.
much, Dr. Maiti. So I'm inviting Dr. Jayanta Goa for his presentation on double whammy, a tale of two IOLs, and extreme PVR, a tale of retinotomy and retinectomy.
So this was the first case
two IOLs, one behind the other. One is dislocated, one in place. This is the shot of the IOL which is behind, and after releasing the IOL as classically is described with the cutter, the vitreous attachments, we put a drop of PFCL to protect the macula. It's a diabetic case, you would realize, and that made my day very long. And this is the retro iris claw lens by my colleague in Amritsar in different center. So we retina surgeons are little daring, so it was easy to cut with the usual Chang 19 gauge forceps. The haptics were cut, but the problem was the optics. It took a long time, long time to cut the optics. So the divide and conquer continued with this help of the scissors, Chang forceps, and seems never ending. And I just struck upon an idea, wild idea, to see. I always thought these retropupillary iris claw lens not stable. They can drop off any time to the vitreous, but it was not so. So first two small pieces I tried. A little bit of madness prevails sometimes. So I thought the lens would dislocate. Anyway, but it was quite stable and I could take it out to the PC. But then I soon realized this is not the correct way. So I went back to enlarging the sclerotomy and taking out the other pieces through one by one. So via pars plana, little bit of extension was required. Yeah. So these Chang scissors are wonderful scissors to cut the IOL. And then the PVD induction, as we all know in diabetes, is very tricky. And it was of the attached hyaloid, the adherent hyaloid. One has to be very patient. I often use the lift and shave technique, as we all use from the periphery to the center, and which becomes easier for the tackling of the vitreous. And then the rest of the surgery was continued. We did endolaser, and in this case we put oil. This was a taco-like situation. They folded after penetrating trauma with giant retinal tear, extreme PVR with folded retina. The endless pursuit of membrane peeling. So I adopt this tug of war technique, pulling tangentially, which I have developed over the years. Initially started by Dr. Cyrus sir, of course. And he was a fourth sandwich technique I use, heel on being the third hand, and PFCL underneath. I'll just show you to settle these retinas. Otherwise, these are very floppy retinas, and you have to do a thorough retinectomy. And once you do a retinectomy with a thorough, I combined this with a chorioretinectomy, in fact, through the wound of entry. Yeah, here some amount of chorioretinectomy was done in this place to prevent PVR. And nowadays, I recently started using a lot of intravitreal mitomycin C in collaboration with my colleague in Turkey, Gökhan Gurulik, but not in this case. So one other trick is to put tangentially. You see a lot of subretinal area. This test was done, heel-on test, and then I removed the heel-on, went back, removed the subretinal PVR, which is not always, doesn't always warrant removal, so the test is required. So you will see iatrogenic, one small tear was formed because I was not pulling tangentially. The trick is to pull tangentially, parallel to the surface of the retina, like in this case. But some vertical pulls, one of the vertical pulls created a small tear, but luckily it was beyond the arcade, so I didn't here. So it was almost a pipe stem like situation. Then again, up beneath the heel-on, PFCL was put as a fourth hand. There you can see the iatrogenic tear. And ultimately one could settle the retina. We got maximum out of near impossible situation. Another case of, this case was operated elsewhere, multiple number of times, 4-5 times, I don't remember. An extensive RD with PVR, they presented to us. Remove the oil, just to illustrate tangential tug of war pull. I did a thorough retinotomy. It's always safer to do a peripheral retinotomy, as Professor Klaus Egard used to suggest. Never try to avoid the posterior retinotomies, as you saw in the previous cases. And I could settle the retina here. I just wanted to illustrate this is the last case, a giant macular hole, almost 7 to 8 disc diameters, roughly 6 to 7 disc diameters. Released the PVR, and this was my first case of, I combined with a autologous retina transplant from the periphery, the harvest area. So once you release all the PVR, both epi and subretinal, here also I did a 360-degree retinotomy, and using the tug-of-war technique, using a spatula and forceps. I use different combinations of whatever comes instinctively in that particular situation. And then this is the harvesting. This was the first case of ART. I've been trying ART in different situations. So dragging and putting the ART over the macular hole. This patient also did pretty well. Finger counting 2-3 meters, not much after multiple surgeries, but patient is happy. And finishing off with the PFCL silicon exchange. Thank you so much for your kind attention.
Excellent presentation, Dr. Goa. So any question from the audience or any of my co-instructor?
Large macular hole, I think amniotic membrane grafting.
It was a giant.
Yeah.
6 to 7.
Yeah.
And I didn't have access. This was done in a different OT, not in Amritsar, where I have access to amniotic membrane. But here I thought, because in those situations, we also found out that ectopic synaptogenesis is seen in ART, not so much in AMG grafts. But anyway, that's another alternative.
But obviously ART is a better option than AMT. That's true.
I'm not sure exactly. I think AMG is equally good. Membrane is better.
There's both factors.
Yeah.
So when it is a giant retinal macular hole, the AMT works better. And nowadays they are suggesting this platelet enriched.
The plasma. Okay,
Ultimately, for such a large hole.
No, it is still inconclusive, especially in this size.
I'm telling the review, the
Yeah.
survey which has come.
Avninder, yeah.
I feel what you do at 360-degree retinotomy and
Not always in, yeah.
it looks very good at the time of surgery, but long-term results I don't find in my cases very good. 4 months, 5 months, I'm not able to remove the oil. There is a persistent hypotony. Where I am wrong and what suggestion you will give that where I should improve to improve my results?
Like two options are there. I am using silicon oil triamcinolone acetonate crystals all around, in all 4 quadrant. And if there is persistent hypotony, I used to keep the silicon oil 5000 centistroke oil for a long-term procedure. Like if you are planning for the silicon oil, until and unless the IOP is more than 12 or 13 or 14, you are not removing the oil at all. And I am using difluprednet, that is difluprednet drops, that is very detrimental for the anterior segment surgeon. But for a posterior segment surgeon, when there is persistent hypertony, if after removal of silicon oil or just before removal of silicon oil, that works
the oil
in
these kind of
30%
cases.
of our cases.
I'm not able to remove the oil.
Now, in some of our cases, there is rise in IOP and could have removed the silicon oil.
One small suggestion, Shubhendu. No, Vishal, I just mentioned during my talk that I've started recently along with Gokhan Gurulik using the PFCL air interface at the end, just before laser. You inject 3 times diluted 20 micrograms per ml of mitomycin C to prevent, and it is working wonderfully in few of my cases. But Avninder's question still remains persistent. When to remove the oil? You can prevent PVR by these methods.
Another problem with so much of retinectomy is that few of my patients have developed NVI after a period of 6 to 7 months. So I can't exactly come to a conclusion why this patient.
Anyway, the take-home message is that this is the last resort.
Yes.
Retinectomy. And because
Get
that's the
that,
only way in
so
this you can
one-
settle these retinas. There is no other way.
One thing should be very clear from the dais is ki retinectomy is not the first choice. Avoid it.
Absolutely.
Yes, yes.
Always the
And
last
until
resort.
unless
It was a
it's
taco-like
necessary,
situation.
don't do it.
Penetrating trauma, extreme PVR cases. That's the last. After peeling, thorough peeling of all the membranes, epi and sub, if you still fail to attach the retina, then retinectomy.
Thank you, Dr. Guha. So I'm inviting Dr. Rajinama Reddy for his talk on intraoperative expulsive hemorrhage and intraoperative unusual blood clot.
Thank you, Dr. Subhendu, for giving me this opportunity, for making me part of this course. Basically, I'll be showing two cases where we experienced unusual challenges during the surgery. And even though technically they are not very long surgeries, but any challenge during the surgery, you feel a lot of time is being spent, time runs slow, and you feel, it is you spend a lot of time doing that. But so So first case is probably a subretinal SF6 gas that is done. The second is intraoperative choroidal detachment and how it is managed subsequently.
Can start it from here. इसको हेलो इसका लाइन दे दो ना प्लीज.
वही किया.
Is there any is it okay? Is it okay? Okay.
वो सॉर्ट आउट कर लो पहले, यहाँ पे कर दो फिर.
Yeah.
देख लो.
हो गया ये.
Yeah, I think Vishal.
Can I
please-
start?
Yeah, please.
Yes, Vishal, Dr. Vishal. Inviting Dr. Vishal Agarwal, Professor, Agarwal Hospital, Jaipur.
So thank you, Shubhendu sir, for making me a part of this wonderful IC. And I'll be discussing again two cases in the same OT, and not just the longest retina day, the longest day, as Dr. Aditya said. So the first case was not looking very complicated. It was a post RVO sequelae, treatment naive patient, right eye, 45-year-old female, hypertensive, and had a combined detachment and diminution of vision in the right eye for the past 3 to 4 months. And this was the OCT, and you can see that macular hole, you can see the traction, and you can see the subretinal fluid, and a lot of ischemic retina around that attachment. So we started the surgery, and we knew that we would require a bimanual dissection because the prolif was quite flat, and on clinical examination there was no seemingly adequate cleavage plane so that the cutter might go inside through it. So firstly, we induced the PVD from the disc and did as much dissection as safely possible through a unimanual approach, and dissected the vitreous around that proliferation. And just tried to remove all the appendages here and try to dissect, and taking care that because of the thinned out and ischemic retina, there should not be any iatrogenic break besides the already present temporal to the fovea. And this I'm segmenting it to small islands as much as possible. Now we have shifted to the bimanual, and still I'm using the cutter so that most of these specs are segmented and loosened up from the underlying retina till possible. But once I realized that no more cutter width is available to go beneath that polyp, I switched to scissors. And now the dissection is done with the curved scissors and the forceps. And I'm able to do it quite well without creating any additional breaks. And all the polyps come out gradually from the retina. They detach from the retina without causing any underlying break. These are all loosened up proliferations which have been dissected, and they are eaten up by the cutter. One final temporal proliferation is still left. And that is also finally taken care of. And now the main point is that the hole at the macula is temporal to the fovea, and it's right now covered under the heme. And we now clear the heme, the membranes and the clots. Not much of bleeding is there because we have already given a pre-operative anti-VEGF, so it's a acceptable bleeding of this magnitude case. And now we have cleared all the heme. And because there's a long-standing traction, we double stain it, and we use triamcinolone, remove all these second membranes, do a peripheral 360-degree indentation and shaving of the vitreous base. And finally, because of the long-standing traction, we also do some ILM peeling, and that is also uneventful. And you can see now that the temporal hole which I was talking about, now it's clearly visible. And we do all the laser because it was treatment naive. And now, under air, the PF seal is there. Now I am aspirating through that hole to aspirate the hole. Now you can see that macular fold. And I had a previous case in which I left that macular fold and I had to reoperate because that was persistent. So I injected PFCL to remove that fold and again aspirated the fluid. And this was done at least 4 times. When I aspirate the fluid and remove the PFCL, the fold again develops. So I was sure that at the end of the surgery, there was a fold, and I was sure that I would, actually require another surgery because I had required in the previous case also. But to my surprise, it went off well. First day, there was submacular fluid, but this is a 7-day post-op photograph, and the fluid has almost resolved. The laser burns are adequate, and there is no traction, and this fluid, of course, will resolve in a month's time. The second case is a more severe case. This was the second case. The patient is a 65-year-old female, pathological myopia, blunt trauma, and 1 month back. And the patient was referred. There was a total RD. They were kissing choroidals. This was the faint funnel which we could see from the fundus. And there was a traumatic cataractus lens subluxation. And this is the USG of the patient. So we did multiple things in this. So there was no chance of 4 mm cannula. So we went through a MVR, as Dr. DT was saying, that the MVR might have drained something. We could see the tip of the 6 mm cannula. We made the other 2 ports with the 25 gauge and with a vent. I am withdrawing the trocar so that in the hope that some blood is drained, but it is not doing. Even if the tip of the cannula I can see in the vitreous cavity, but still not the blood is not coming through it. I also tried posteriorly to what the position is right now, but still there was no blood. Finally, I put a AC maintainer here, and that worked. So some amount of drainage is now possible, and you can see the bleed oozing out from the vent of the cannulas. Then finally, because of the subluxation, we did a lensectomy, and it was grossly subluxated, so the remaining nuclear matter was inside the vitreous cavity. Now we are in the vitreous cavity. You can see how less space we have. The choroidals are temporal, nasal, all around. This is a very small space we are working, and the maneuvering is really difficult. So you can see RD, you can see a CD, you can see subretinal bleed, and you can see a dropped nucleus there. So we injected the PFCL to protect the macula. And of course, this was a hard nucleus, so we used the frag and did a fragmentome, and we removed that nucleus and drained the subretinal fluid also. Still, that infusion is through the anterior chamber right now. and we injected tricot to complete the PVD and all the vitreous dissection. But at this point of time, I thought that the fluidics are not working in my favor, and the flow is very less through the cutter. So we switched from the interior chamber maintainer to again the 6 mm cannula. Now I could see the tip clearly, and with still comparatively more space to work on. And you can see now the fluidics are working fine. We did a peripheral vitrectomy base dissection as much as possible in this scenario, drained more subretinal fluid, injected more PFCL. And as I was aspirating the PFCL, some more blood keeps on trickling to the posterior pole. So we left a small bubble of PFCL at the posterior pole and did an adequate laser. And of course, there was an underfill, and I was expecting underfill. And we are also expecting a re-detachment, but that is a fight for another day. So, but we could complete the case. We could flatten the retina. And this was around 15 days post-op. You can see the choroidals have resolved. There is a redetachment with a small fold. We again went inside, and the patient is doing fine. So it required multiple surgeries, but the final outcome was good. Thank you so much.
I have a small suggestion, like Vishal, when there is almost like kissing choroidals, even the lens is clear, you have to do the cataract extraction to get some space behind the IOL. So that will increase the case, because the volume of the lens, cataract, it is roughly 200 microliter.
Yes.
And volume of the IOL is 20 microliter. So you are getting extra 180 microliter space. That is great enough to do your surgery more completely. And second thing, when you are draining the suprachoroidal blood, that you have to drain it from more posterior.
I mentioned that. I also used a posterior retinotomy, the choroidal drainage, but that also did not come out. Although it was liquefied on the USG, but it still did not come out.
Okay, but nice presentation. Dr. Talwar, please. Yes, Dr. Manisha.
Yes, madam. Yes.
Dealing with. I personally felt that the subretinal fluid could have been very viscous.
Yes.
Now, when you've injected the PFCL, it has actually caused a little locculation of the fluid in the area of the TRD. And when you are trying to drain the fluid under air, it's not really coming out, and that's why when you remove the PFCL, it's causing a macular fold. I personally feel that if you would have done a fluid exchange first before shifting to air, probably it could not have landed in that macular fold.
Okay. And do you recommend leaving that macular fold on table?
Sorry?
And you expect it to resolve by itself? Do you normally leave that amount, that magnitude of fold on the table, or you try to flatten
actually, because the only problem is that it's such a chronic SRF, it will take a lot of months, quite a few months to actually settle down.
But it resolved in a week.
It resolved because, it was a small pocket of fluid which you had it loculated over there. You've injected PFCL, you've drained the fluid which was in the area of your drainage retinotomy. And that is why that just caused a little bit of fold. So usually in these cases, if you do a fluid exchange, you'll get a more complete drainage of the fluid and you'll not face this problem.
Because this TRD fluids, fluid, it doesn't go away.
Yes.
And even I tried using that snake flute, if you remember, extendable soft tip, which you can take under the retina, and then
but it does not come out completely.
It doesn't come out that TRD, and though it is combined, though there was a break, that fluid doesn't become that easy, soft enough to come out. So we don't have any option other than leaving that fluid like that only and wait for that. Thankfully, you got it.
But sometimes that fold is persistent, and then you have to go inside.
That's what I'm saying. Thankfully, you got that cleared in 1 week in this case, but the TRD fluid, it takes months. And some of the times you see that spontaneously attached retina kind of a pigmentation also once that fluid resolves. So it all depends on how much time it takes. So as ma'am has mentioned, we have to definitely give it a try about fluid exchange that at least dilutes the tractional fluid. So it may help at least after you leave it there.
And Vishal, do you advise doing 360-degree laser also with those kind of choroidals?
Veera Shalini? Yeah. Can you come again?
Do you advise doing a 360 laser too with those huge choroidals?
Because the view was so hazy, I'm not sure if I've missed any breaks. In a clear media, if you indent and you see and you're sure that the periphery is okay, then you might leave it and just laser the break. But the whole surgery was under a compromised view. So just, to be on the safer side, I, put 3 or 4 rows to create a false error. That's all. Otherwise, I don't do that. Sir? No, sir. Break tak? The first case? Yeah.
ये नहीं नहीं दिखा
At the macular area only, sir. Yes, yes.
One thing I have found is certain of my cases, the traction extends beyond the artery. So even if it was not settling with fluid exchange, then I extended my ILM peeling beyond the arcade, and that fluid and the retina settled over it.
Dr. Gupta,
So, but the
yes,
etiology
due
is
to
that viscous fluid.
lack of time, I'm just keeping.
Yeah, sure.
Thank you. It was a very dynamic presentation, Dr. Vishal, as usual. So I'm inviting Dr. Reddy for the next presentation on intraoperative expulsive hemorrhage and intraoperative unusual blood clot. Dr. Reddy, please.
नहीं आ रहा ना नहीं
Dr. Reddy, is it okay?
नॉट येट आई गेस यहाँ पे डिस्प्ले नहीं हुआ हाँ ओपन कर दिया ना
Yes.
क्या पे कहाँ दिख
At last.
यहाँ पे कंट्रोल नहीं है वहाँ पे तो okay
Next. Is it taking time?
या
Yes.
यहाँ पे तो दिख नहीं रहा कहाँ है दिस चैलेंज हियर यहाँ पे कंट्रोल नहीं है नहीं नहीं कहाँ है दिख नहीं मेरा कंट्रोल कहाँ है
शुरू करो भाई. So,
मैं दे देता हूँ यार वहाँ पे प्रेजेंट कर दो ये कॉपी द फाइल
due to some technical glitch, Reddy's, you have to take time.
yeah yes that's better yeah.
मुझे भी लगना पड़ेगा.
So I'm requesting Dr. Shobik Da to start his presentation. इसको दे दो ना इसका इनका दे दो. हो गया क्या?
तेरा यही है ना
इनका दे दो.
मैक क्या
So this line, this one. इनका लाइन दे दो ना.
अच्छा कीनोट है.
Yes. Dr. Shobik, please. Dr. Shobik Da is presenting on bloody mesh with ARG. Audio, please.
Audio, please.
Audio, please.
Hello, everyone. Thank you, AIOC and Dr. Shubhendu Baral, for giving me this opportunity.
Audio, please.
Coming to case number 1.
60-year-old female complaining of dimness of vision for last 8 months. The best corrected visual acuity was 1/60. On the left eye, there is NH2 cortical cataract with a large macular hole with a base diameter of 1020 micrometer. So the plan of surgery was pars plana vitrectomy plus ILM peeling inverted flap plus ARG plus silicone oil injection under local anesthesia. So after doing core vitrectomy, triamcinolone acetate was injected into the eye. Then PVD was induced very gently. And the vitrectomy was completed. DBG dye was injected to stain the ILM. Then I started to peel ILM very gently. My idea was to cover the autologous retinal graft with an inverted ILM flap to avoid future displacement of the graft from the macular hole area. Then, by using a 41 gauge needle, a subretinal blade was created outside the arcade. Then, using one forceps and one curved microscissor, I tried to cut a retinal tissue for grafting purpose. The ideal size of the graft should be 1.25 times of the hole. Everything was going as per my plan till now, until I made a blunder by cutting a major retinal vessel during the procedure due to my inexperience. The bleeding started from the wound margin and everything was messed up. I tried to separate the tissue as soon as I can with increasing the intraocular pressure because the bleeding was encroaching towards the macular area. I decided to inject heavy liquid PFCl to stabilize the bleeding by applying positive pressure. Then the graft tissue was separated and under PFCl I tried to drag the tissue towards the macular hole area by the help of a tandem stretcher. Then I covered the autologous retinal graft with the inverted ILM flaps by all sides with the help of max grip forceps. All the procedure was done under the PFCl. Fluid gas exchange was done and PFCl was removed. Barrage laser was applied at the margin of the donor area. At last, I wanted to remove the bloody mess. So with the fluid needle and the cutter, I tried to drag the blood clot away from the macula. But during that procedure, oozing had started again. I quickly removed all the blood that trickles towards the macular area and closed the case with injecting 1000 CST silicone oil. It was not a clean-cut surgery, but I console myself that the hole was closed by the graft and the ILM flaps as I planned. After 3 weeks of post-op, the hole was closed in all directions and the blood clot was barely visible. After 2 months of the post-op, the graft was stable. The vision improved to 6/60 in the left eye. Post-op multifocal ERG results was also showing some amount of restoration of the macular function in the whole area. Thank you for your kind attention.
Now coming to case number 2.
Solving the riddle with a twist. A 60-year-old female patient having a history of laser PDR with a chronic DME came to my OPD with a history of PCIOL implantation and multiple intravitreal injection and Ozurdex implant in both eyes. She had a history of phacoemulsification with a toric IOL implantation in the right eye 7 days back. But as per the primary surgeon, the surgery went uneventful, but at last during the IOL implantation, the IOL went into the vitreous cavity by a downward trajectory, tearing the posterior capsule. The surgeon placed a multi-piece IOL in the sulcus and referred the patient to VR department. So what are the challenges now? First of all, preserving the Ozurdex crystal. It is very essential to keep the crystal in the vitreous cavity to prevent the post-operative CME, as it was a chronic DME case. But as the crystal is freely movable, it is very difficult to preserve it during the vitrectomy procedure. Number 2. PVD induction. It was also very difficult as it was a laser PDR case, so it has to be done very gently and slowly. So after the vitreous removal, the ischemic retina was lasered thoroughly. Now the next hurdle came. How to remove the dropped single piece IOL? As the multipiece IOL was placed in the sulcus, it was literally impossible to remove the single piece IOL without cutting it or removing it through a SICS wound. So is there any way to kill the snake and save the stick? So I thought of explanting the single piece IOL by twist and out technique as described by Dr. Rahul Pandit et al. Published in Journal of Cataract and Refractive Surgery in 2020 in a modified manner, where a pre-existing multipiece IOL was present in the anterior chamber to avoid an extra scleral incision in the eye. First, the multipiece IOL was dislodged from the sulcus and brought above the iris plane. Then, the single piece IOL was grasped by a mag screw forceps and brought into the anterior chamber just below the multipiece IOL. Copious amount of dispersive viscoelastic substance was injected to protect the endothelium. The optic of the single piece IOL was grasped firmly by a McPherson forceps. A dumbbell was inserted through a paracentesis incision and placed above the multipiece IOL. The optic of the single piece IOL was grasped with a hand completely supinated. The hand is then completely pronated while rolling the PCIOL around the forceps using the dumbbell to guard the cornea, thereby removing the PCIOL entirely through a 2.8 mm incision. Then the multipiece IOL was reposited in the sulcus and anterior optic capture was done. The viscoelastics was thoroughly cleared from the anterior chamber and fluid air exchange was done. Finally, I closed all the ports and finished the case by hydrating the wound. After 2 weeks post-op, the best corrected visual acuity restored to 6/12 in the right eye with some amount of cell and flares in the anterior chamber with a fine regressing membrane in the pupillary zone. The post-op OCT revealed almost dry macula. Pre and post-op specular microscopy also confirmed the corneal endothelial health was preserved after this maneuver. The Optos picture proved the existing Ozurdex crystal inside the vitreous cavity. Thank you for your kind attention.
Thank you, Shobik. It was a very daring surgery. Second one. Second thing, thank God that even after removal of the second IOL and placing the IOL over in the sulcus, the capsular rim was absolutely fine, stable. So, any question from the audience? Yes.
Good amount of flaps of ILM in the first case.
Yes.
It would have been closed, with gas and just a little more inversion. Why did you venture in cutting the retina and trying an autograph? That flap would have been sufficient to close that hole.
Yes, that is true. And you have to take the graft after doing the barrage lasering that graft area, donor area.
Actually, I thought that doing barrage laser or doing the some amount of cautery actually hampered the healing process.
Yes, and that was your first case.
Yes. Yes, I accept.
When you remove the cloth, like in the end when you try to remove the cloth, at that time you should not drag it from the vessel because that opens up again.
Yes. Keep the clot there.
So you trim it with the cutter rather than dragging it from the clot
Thank you. Thank you, Dr. Rama. Point well taken.
Yes.
Yes. And Dr. Reddy, please carry on.
Yeah, thank you for your patience. Yeah, these are two cases that I'll be presenting. Pretty unusual. I haven't had, at least the first one, I didn't experience it before. This is a 55-year-old phakic male, sudden diminution of vision of 1 day duration. I wasn't around, so I was traveling. My colleagues thought that she would better offer a pneumatic retinopexy, and then avoid a vitrectomy in this case. So this is how 24 hours after pneumatic retinopexy, but the colleague could not achieve a good laser of this causative break. So 48 hours after injection, this is a kind of the RDS progress, the subretinal gas. And at this time, we offered a vitrectomy surgery, and this particular patient we planned I promised him that we'll be doing it under gas to prevent any recurrence, to prevent any resurgeries for another removal of silicone oil. So this is how it was: gas bubble in the vitreous cavity, as well as some in the subretinal space. 72 hours, this amount of vitritis also is developed. Initially, I did not give too much importance to how I'll be removing the subretinal gas because I thought it would automatically come down in some way or the other. Okay, and then following vitrectomy and trimming the retinal flap, indentation vitrectomy was done to remove the vitreous base indentation. And then you can see all these bubbles separately. Even that time also, I didn't give too much importance how they'll be coming out. I thought through the causative break that is there at 12 o'clock, they would be easily coming out once I inject PFCL. So PFCL was injected. It was difficult they did not come out through this break at the 11 o'clock. So fluid gas exchange was being planned, air fluid exchange. And after air fluid exchange, you see that, some bubbles are still there and in the same position and they are loculated. And for some time, I thought I'll do laser around. You can see that they got coalesced to something. You can see this is a laser bubble anterior to the break. I thought I'll just barrage all these bubbles and then leave them like that. But this, of course, small gas bubble that did come out through the break. So that was sorted. So there are bubbles in the inferonasal quadrant. I thought I'll try to move them into this position, but instead of displacing along my area of interest, they progress posteriorly. And I was in a spot here, and for some time again I thought I'll do a barrage around this gas and then leave it alone. Then I realized it's not a great idea because they are expansile SF6 bubble. And even while barraging, I couldn't do a complete, there was some amount of probable SRF around the gas bubble. So I could not laser one edge, the posterior edge of this bubble. So any manipulation was further discretion. At this time I did a retinotomy and drained it to through the retinotomy. And then subsequently SF6 gas was injected in this particular case, and the feathery cataract disappeared and is doing well at this stage. The second case is of a 65-year-old female, pseudophakic, diminution of vision for 3 months, some amount of anterior uveitis and retinal detachment with shallow choroidal detachment. And you can see inferior pigments and mild PVR grade B. She would offer a vitrectomy surgery. So 25 gauge. 3 minutes, this is an edited video into the vitrectomy, I realized that there were few choroidals increasing in the periphery. So I knew there was shallow choroidal, but they increasing in the periphery. At this stage, I thought it could be a suprachoroidal hemorrhage. And through the resight, without taking out the resight, I was indenting and seeing if the cannula is in position. I realized there is a cannula in position, but that cannula was the other active port. So one port, probably during the surgery, it got retracted and went into suprachoroidal space. So this is something that could have been done differently. So I removed that, put in a 6 millimeters cannula and then ensured that there is it's in place in the vitreous cavity. Now the important part is draining the choroidal. I did convert in 20 gauge as was my experience before, but it couldn't really drain much of place. So I did drainage through trocar, through the valveless trocar and periphery, and posteriorly. It did resolve initially at first placement, it did choroidals reduced, and while removing tangentially, slowly removing and pulling it apart, the choroidals got almost drained, the posterior valveless trocar. This has been my favorite technique of draining choroidals or suprachoroidal. It has worked well for me. But on this day, I was going to have a surprise after this. I could see that there was some hemorrhage in the periphery. During further PFCL, then I was more surprised that breaking the PFCL, the hemorrhage was going posteriorly, subretinally. So this is how it was. And at the time, I planned urgent laser, 360-degree barrage was done, and all 360. And you can see that some loculated subretinal hemorrhage in the periphery. And I also cryoed probably the causative break somewhere. So after doing this thing, I asked my colleague to take over and just do fluid gas air PFCL exchange and silicone oil injection. So it so happened that while ideally PFCL silicone oil exchange should have been done. So while removing the PFCL, we slowly see that that hemorrhage in the periphery is coming down posteriorly and shifting posteriorly, and I think video stopped. Yeah, posteriorly, and almost at the time of complete removal, it is almost submacular hemorrhage. So quickly at this time, I did a retinotomy at that site. And removed the subretinal hemorrhage that was still unclotted. Yeah, so it did easily come out, and that's how I saved the day for myself as well as for the patient. Yeah, this is how it is post-operatively. It's doing good, and subsequently after 2 months, and she's scheduled for silicone oil removal. Thank you.
Thank you, Dr. Reddy, for your nice presentation. Any questions from the audience or any of our instructor, please?
The first case, there were two small bubbles which actually collapsed and became one big bubble.
Yeah.
Even if it had left it, it would not have caused a recurrence, I feel.
There was some. That is 100% SF6. Yeah, 100% pure SF6. At the time of injection. 72 hours. 72. We tried. Yeah. I did.
So I'm starting my last talk. That is the slide, please. My longest day. Put up the light, please. Light, please. So first case, it was a routine case of retinal detachment, I thought. And as usual, I was starting doing PVD induction. And there was an inferior break. Not much of adhesions, not much of PVR. So doing triamcinolone acetonide assisted vitreous base dissection after injecting the PFCL. And there was almost a big single break, whatever I thought, and did all vitreous base excision as usual. Nothing surprise, no other surprises. I cauterized the break, and there is small 2 breaks along with this large break, and did fluid exchange from the peripheral that break, and started doing laser. And the surprise started happening while doing the laser. What was the completely it was not very. See, apart from the 2 breaks, wherever I am doing the laser, lot of multiple breaks are coming, one by one. It was not there previously. Just like a sheave, appearance. It's not the power. It is the retinoschisis, inner retinal holes. Yes.
I adjusted the power at that time, but there was multiple breaks that happened alongside that. Yes. So multiple inner retinal breaks that become, that was a case of retinal detachment with the retinal schisis. Infratemporal quadrant, common site, you can see, and lot of multiple breaks you can see here, sieve-like retina, but in other areas with the same power didn't happen. So these are not power induced, Dr. Vishal, for your kind information. So that was the first thing, case. And second thing case, it was like as usual, myopic retinoschisis with myopic macular hole. And while doing the triamcinolone acetonide assisted vitrectomy, followed by staining the ERM and trying to remove the ERM with the help of max grip forceps. It's very difficult to reach it to the posterior pole. I removed this cannula, try to see the membrane and grasp it, and fortunately I removed the membrane, but it was very difficult to remove the ILM at the time. So I just barely removed the peripheral vitreous. Then I used cutter only to reach the residual membrane, whatever there in the posterior pole. With the left hand also, I couldn't. Just tried to remove the peripheral membranes after depressing the periphery as much as possible, but tried again with the max grip forceps. But finally, I used this Phenaciflex loop, and for me, it is quite helpful to be used in cases of myopic macular holes, because it can reach the posterior pole and peel the ILM and cover the macular hole as an inverted flap technique. So Phenaciflex loop, especially even in like normal cases, non-myopic cases can be used, but especially in myopic cases with posterior staphyloma, these are very much useful to do the complete the ILM peeling from all around, although it will not be a very very neat manner, but still you can cover the macular hole with this Phenaciflex loop, with this loop only. Because long instruments are not available easily, so I did fluid exchange in this case and ended the case with the gas tamponade. My third case, it was a case of recurrent retinal detachment with paramacular hole. With recurrent RD, I have shown this case to VRSI and last conference. Vision was hand movement close to face, PR was accurate. And there's almost total RD, a small paramacular hole was there. I stained the macula to reveal some kind of any ERM was there or not. And I just removed small membranes, mild, so membrane was, PVR was not much, just gently did the cautery, planned not to drain it through the paramacular hole, and started doing fluid exchange through the nasal retinotomy. Just see what is happening with the this paramacular hole. It was slowly enlarging, and just see, just enlarge quite a bit. So when I started doing fluid exchange through the retinotomy, it started just enlarged the hole, and there was subretinal air. You can see the hole suddenly becomes giant in configuration, and I used PFCL. There was no other option for me. And here comes the second blow. You can see there is subretinal migration of PFCL. So hardly a 15 minutes job now becomes a huge mess for me. Like I did temporal retinectomy to mobilize the retina to close that hole, because I have to close the hole. And another is there is subretinal PFCL. So like.
You knew that your course was accepted, so it was done intentionally.
So I did removal of the PFCL, subretinal PFCL through the break, tried to oppose the all whole margin, little bit smaller, but it was not. So before that, I didn't do a single case of autologous retinal graft. So I used this long back, cut the peripheral retina under the ear, tamponade, and migrated this graft, transplanted, harvested the graft from this area under the ear with this phoenocephalix loop up to the macular area. But the hole size was extremely large enough, giant enough to cover the graft, cover the hole with this graft size, with this size of graft. You can see the break was not fully covered with the graft, and I did little bit in the foveal area and partially temporally aligned the graft little bit, and there was still some kind of gap was there, and did little bit of laser, because it's such a large graft, whether it will be staying at the in situ or not, it was very difficult to predict, and did laser, and finally siliconal 5000 injection at the end of surgery. And I was fortunate enough that hole was closed with some kind of spikes on this ERG. Thank you. So I asked in previous years also. Yes, Dr. Talwar, please. What was the reason for the enlargement of the hole, whether it was the cautery or there was unnoticed like tractional elements, invisible traction? Should I remove the ILM or not? Intrinsic contraction could be. Yes. This invisible PVR. Sir, please tell me.
First case was described peripheral degeneration called diffuse choroidal atrophy, happened high myopia and temporal quadrant. You can see the textbook is there.
Okay.
I have one case where I have 30 holes in that area, within a small span.
It's not due to laser.
It's not due to the laser. The breaks were already there, you highlighted them.
Subhendu,
yes.
Excellent surgery, but the first surgery is not long enough to fit in this course.
But it's an unusual thing, that's why I've shown it, because many of us may not be.
But
Okay.
in the second case, when the ear went subretinal, that was the clue that the PFCL might
Go again, subretinal. Last case, yes, yes.
So just
Sir,
to-
please.
In your second case, which lens were you using for visualization?
The Volk,
The high myop.
high myop, yes.
Which lens were you using?
Volk, contact lens.
Were
Not
you using contact lens? or were
contact
you-
lens.
The wide field wala.
Yes, white field bulb.
Not, see, basically, one problem that happens is that when you have, especially with the, these wide field systems, the shaft
Landers,
goes and touches the
Yes, that's
lens.
the
So
main
you don't
problem,
end up
yes.
getting. But if you use a Landers system, this problem
Yes,
goes away.
yes.
Most of the times, the
Does
size
almost-
of your shaft will be enough for a Landers system, and even allow you to do a little bit of depression there to reach the height. Very few eyes which will not be within the range of the forceps if you're using a Landers system. So that's the first thing. So I actually never faced this problem because I always used the Landers system, and I used to wonder why is everyone getting a problem.
We left a lander system
So
long back,
yeah,
that's
so
why,
so
yes.
so the simplest solution is
Yes.
to use a Landers system. You get a better visualization, you get a better magnification, and you get no problem with your shaft length also. So this was the second case. For the third case, the moment you have a situation where you have this kind of traction, this is traction, this tangential traction which is occurring at the retinal surface, there's probably a very thin layer of vitreous schisis which is lying over there, which needed to be removed. And because that was not removed, so it pulled it off. And that's why I was wondering why you didn't do that, because
Sir, I stained all kinds of like staining process.
no, so when you
materials,
stain,
like
see when
tricot.
you use tricot, you have to then remove the tricot and see whether any crystals are left on the
Left on,
retinal
yes.
surface. If you see any crystals on the retinal surface, that's your clue that there is a layer over there. And this layer can be either piecemeal or it can be a complete sheet. If it's a complete sheet, this is what you would get. If it was piecemeal, you would have gotten away with it. In fact, that was there till the end, because if you see under PFCL also, you're seeing there's a reflex coming. If you see, there's a sheen coming from from the edges of the hole, which means that's still there. So actually, the first issue was not removing that. The second was to put the PFCL in the presence of that. You should have put a little PFCL only to stabilize at the posterior pole, then tried to clean up as much as possible. You would have probably got the membrane out, the vitreocysis membrane out. Then you extend. See, the basic thing is PFCL works very well if you balance out the amount of PFCL needed versus residual traction there. Even if you got D3 and you put a little small bubble of PFCL, opens up the eye, opens up the retina, extend it. The membrane becomes taut, remove it. Now put some more PFCL, extend it. You could have done the same here. A little bit of PFCL, more on the nasal side, coming a little above from the disc to the macular side. Then do the use a diamond dusted to clean it up, or a finesse loop, whichever you prefer. But it has to be new, whatever you use, and you'll get the edges. And actually, you've actually got an eye which already has traction, and you put in the graft on top of it. So actually, this solution is not over yet.
Yes.
You will still need to take care of it.
Shubhendu, may I ask you one thing? Yeah.
Yes.
So, why did you diathermize the parafoveal, the diathermy?
Because it was such a small hole, I could have easily missed it. So that's why maybe that was not needed. Yes.
The thing is, you have the pathological high myope case where you do invert ILM peeling. Sometimes actually it's very difficult to see where is the macula and where is the fovea.
Yes,
doing
yes,
this
yes,
kind
yes.
of without intraoperative OCT, it becomes.
It's
so
very difficult.
where exactly you invert all these.
We don't have
flaps that you're going to
intraoperative
put.
OCT.
How do you make sure you know where the macula is?
By after staining the whatever 2 to 3 times, I'm staining in all of my cases where the background choroid reflex is not there.
That amount of posterior cephalum and pathological macula equates to around 30 mm of axial length, and you can easily go to 4.5 mm.
Oh yes, we're just discussing this.
4.5
Yes.
mm will not touch the retina, and you would easily go with the routine instruments to the posterior pole.
Okay.
Both, that's the other alternative. Going temporarily a little more periphery and then doing it.
Removing the cannulas, I do this.
So thank you.
One last comment.
One last comment. Yes, please.
Okay, the recent interview, I'm not sure whether you have all seen the recent interview of Sunita Williams. She was asked about the secret of her longest stay in the space, and what she told was she attended this course last year.
That should be the last comment. Yes.
Thank you. Thank you for your gracious presence. Thanks a lot.